Hello, I'm John Foster, and I'm a medical doctor who does Social Security disability exams. And today's video is intended for other doctors who do these exams. I'm going to talk about some tips I've learned over the past 5 years doing Social Security disability exams. As usual, everything I say reflects my own opinions based on my own experience and study, and not the opinions of the Social Security Administration or any other medical body. Now, to start off, I'd like to go over one of my pet peeves. In the CE packet, or consultative examination packet, Social Security used to include what they called special instructions for every patient. These were the questions Social Security wanted answered about that particular patient and gave the physician information as to what systems to focus on. I've had patients with over 20 separate complaints for their disability claim, and it's impossible to evaluate each one in detail. There simply isn't enough time. So when I used to get the special instructions, I could focus on the questions Social Security wanted answered and provide much better reports. They stopped providing these special questions about a year ago. And if anybody from Social Security is watching this, I would implore you to resume including special instructions again. Right now, all I can do is guess at what Social Security is trying to get out of the exam and hopefully answer the questions that are in their mind. Because these examinations are so comprehensive, it's important to use each minute to the best advantage. My examination begins either when the patient enters the room or even before they enter the room. In the office where I work, it's often visible to me, but not the patient, when they walk down the hall to get their vital signs and vision checked by the medical assistant. And if I can, I watch the patient walk when they don't know they're being observed. Any abnormalities of gait when the patient doesn't know the doctor is examining them, to me, are more significant than abnormalities of gait that may appear during my exam. Likewise, I pay close attention to the way the patient walks into the exam room, sits down on their chair, and if they have any, puts their personal belongings on the floor. I look for things such as shortness of breath, difficulty walking, difficulty sitting down, difficulty bending over or manipulating personal belongings to put them on the ground. I note if the patient can hear and understand my normal conversational speech. If they can't and I have to speak loudly, then I consider them hard of hearing and I put that down in my report. Likewise, Social Security is very interested in patients' difficulty breathing, and if they're having trouble breathing just sitting in a chair with no exertion, I put that down. Social Security also wants to know if they become short of breath with minimal exertion, such as walking on the heels and toes, which is towards the end of my exam. Often I'll see somebody who's mildly short of breath at rest and moderately short of breath with minimal exertion, and I put both down in my report. As I'm beginning the history, I want to make note of the patient's mental status, and here are the things Social Security is interested in. Number one, personal appearance. Is the person clean? Are they neatly dressed? Do they appear intoxicated? Next, are there signs of neurosis? Most commonly, signs of anxiety and depression. In the past month, I've seen 2 patients with severe signs of neurosis, and severe is a key word for Social Security. If you look at the listing of impairments, most impairments have to be severe to qualify as disabling. I had the patient with an extreme history of childhood sexual abuse, incest, and torture who was severely anxious throughout the exam, And most recently, I had an unfortunate man who was in constant pain from arthritis in multiple joints and also was having blackout spells, who was extremely depressed over his disabilities to the point where I felt the need to ask him about suicidality. If there are any severe signs of mental illness, be sure to put them in your report. Next, are there signs of psychosis? This is fairly rare, but from time to time I get a patient with schizophrenia who's having active auditory hallucinations during the patient encounter. Finally, Social Security wants to know, how does the patient relate to me and staff? Do they relate well, or are there problems? I had a patient on the autism spectrum last weekend who had difficulty relating to me and staff due to his autism. It wasn't severe, but he had multiple other problems, and perhaps the autism would be the deciding factor between his claim being denied or approved. Another thing to note during the history is the patient's general intelligence level. Now, to qualify for Social Security based on mental retardation, one has to have an IQ 2 standard deviations below the norm, 70 or below, and that's pretty low. However, I do see patients who I think have borderline IQ, which is between 70 and 85, and I always make a note of that because, again, if they have multiple other problems, that may be a deciding factor in whether they're approved or not. Next is assistive devices. These are things such as canes, walkers, rollators, and wheelchairs. Social Security is very interested in assistive devices, and here is what they want to know. Number one, what sort of device does the patient use? Number two, has it been modified in any way? Number three, does the patient use it for standing or walking or both? Number four, does the patient use it in certain circumstances or all the time? And number five, in the physician's opinion, is it medically necessary? I see a wide range of assistive devices, and sometimes they don't seem to be necessary at all. I've had two patients who came in by wheelchair who could walk perfectly normally. On the other hand, I've had patients who definitely needed assistive devices. Once in a while, I'm just not sure. And when I'm not sure about anything, I put down in my report that I just can't tell. There's no shame in being undecided. We are human. We are not all-knowing. If the patient has demonstrated that they're hard of hearing, I want to know, is it in both ears? I had a patient last weekend who had not mentioned difficulty hearing in their list of impairments, but I had to speak quite loudly, and they were definitely hard of hearing, and it turned out they were completely deaf in one ear and partially deaf in the other. They just hadn't thought of it, and I was sure to include this in my report because that is a problem. Three things in the history that Social Security may be particularly interested in. Those are chest pain, shortness of breath, and seizures. For chest pain, Social Security wants a description of the type of pain, the duration, precipitating factors, and relieving factors, and radiation. For shortness of breath, Social Security wants to know severity, precipitating factors, relieving factors, including medications, and whether the patient requires treatment in the emergency department or in admission to the hospital. For seizures, Social Security wants to know the type of seizure, the frequency of the seizure, what anti-seizure medications has the patient been prescribed, and are they compliant with the medications? And I forgot to add, with shortness of breath, Social Security also wants to know, is the patient compliant with their medication? If the patient has heart problems, Social Security wants to know about the heart sounds, especially gallops or murmurs. They want to know about the peripheral pulses, whether there is dependent edema, and whether there is jugular venous distension, clubbing, or cyanosis. And here I'm going to give a tip. When I was in medical school, we were taught to examine the jugular veins for jugular venous distension. As in many areas of medicine, as our patient population grows fatter, this is more and more difficult to evaluate. So here's an easy way to evaluate jugular venous distension in most patients. Look at their hand veins with their hand dependent. If you can see distended veins, have the patient gradually lift their hand until their hand veins collapse. That is the level of their jugular veins, and you can measure that and figure out if they have jugular venous distension or not. For patients who are short of breath, again, Social Security wants to know if they're short of breath at rest and if they're short of breath with minimal exertion. Also, they want to know, are they using accessory muscles of respiration? Is there an increased AP diameter of the chest? Are there abnormal breath sounds? And is there clubbing or cyanosis? Next is wounds. If the patient has had any recent wounds, either traumatic or surgical, be sure to indicate whether the wound is well healed or not. Social Security considers open, unhealed wounds very significant. Likewise, if a patient has had a limb amputation, Social Security wants you to examine the stump, see if it's healed, see if it's in good condition, or if it's unhealed or the patient's having problems with the stump. Another thing Social Security considers very important is brawny edema. If the patient has brawny edema in their legs, they want to know, is it in one leg or both? And how far proximal does it extend? And is it mild, medium, or severe? I do the agility tests and balance tests at the end of the examination. And for the abdominal exam, I have the patient assume the supine position. After I've examined the abdomen, I ask the patient to stand up from the exam table, and I don't assist them unless it's absolutely impossible for the patient to get up on their own. Any difficulty lying down or rising and standing from a supine position is very important, and difficulties may be due to pain, muscular weakness, postural hypotension, or balance issues. I then have the patient walk back and forth in the room, then walk on their tiptoes, walk on their heels, walk heel to toe like a sobriety test, and squat down as deeply as possible and then rise back up to the standing position. If I notice any problems with any of these tests, I record that and put down the reason why. Again, if I don't know the reason why, I put cause unknown. Don't guess. Finally, I do a Romberg test on everyone as the last test in my exam. I've been quite surprised sometimes when patients with no complaints of problems with their balance, and even some patients who could heel toe walk well, have a positive Romberg test. And poor balance is definitely a problem with working. For example, you don't want somebody with poor balance working on a roof or on a ladder. Well, I hope you've got some useful tips and that this has been helpful. And as always, remember, if it happens, it's possible.